Right. Hello, good evening, everybody. And thank you all very, very much for joining us this evening for this very, very important topic today. I am absolutely delighted to have four wonderful people here with us today. I will introduce them, when the time comes, but I really, myself, and all our staff in Kuwait are really, really grateful for their contribution and for them joining us this evening. I see within, the attendance is Professor Mustafa Khojali, my good friend, teacher, and colleague. And I would like just to extend a very warm welcome to him. Mustafa, for those of you who do not know him, is truly the father of occupational medicine in Africa. I know he wouldn't like me saying this, but welcome, Mustafa. Mustafa, and I hope we will get to hear from him later, David, if we are able to. The topic we're speaking about this evening is a topic that is close to my heart personally, to us in Kuwait, and absolutely, I have absolutely no doubt to every one of our panelists here. This is, uh, our role in occupational health is to look after the health of workers, of people who work. Interestingly, healthcare is not thought of as work for a reason. We thought to be, the people who actually just go and look after people, and actually no one, thought seriously about looking after us. I think COVID-19 was a wake-up call for absolutely everybody, for politicians, for policymakers, for and for the healthcare workers themselves. Um, when we speak about protecting the health of the healthcare workers, this is not a theoretical. This is absolutely something that we deal with every single day. Every single day, we are faced with problems. I would like, if you all allow me, the panel.
I think you're muted. I I don't know if it's just me, but I cannot hear.
I also cannot hear. I think something went.
Can you hear me now?
Yes.
Yes.
Okay, okay. Right. Um, I was saying I would like to, dedicate this webinar to the memory of all our colleagues who lost their life, in the front line, trying to save, their patients, communities, and hold, the fort in very, very difficult situation. I'm just going to go very quickly through, histories of three of these people. Um, the first one, probably Mustafa would remember this young chap, Dr. Abdin Khairi, who lost his life at the age of 26. Abdin Khairi was a general practitioner in the South Sudan. Now, that was part of Sudan in 1976 when the first Ebola virus struck. Nobody knew anything about Ebola. He worked in a hospital called Maridi Hospital. 41 healthcare workers out of about 200 individuals lost their lives to the Ebola. That the story, I would urge all of you to have a look at the, this article, which was published in the Sudan Pediatric Journal in 2014. This was when, all the organizations came together to actually diagnose Ebola. Abdin was only 26. He stood his grounds. His colleague came from another hospital nearby, transferred him to Juba. He was transferred to Khartoum, and he passed away in Khartoum South Wing there. Interestingly, and Dr. Mustafa is here, Professor Mustafa would remember that same week, the late Dr. Abdulghafar Abdurrahim formed a medical team and flew to Juba. Fortunately, none of them, was affected. But that was, the WHO assembled an international committee, and I think, the study of that outbreak of the hemorrhagic fever gave the world its fairest Ebola virus. The second doctor is Dr. Pepita. Dr. Pepita is a pediatrician who lost his life to COVID-19 in 2020. He was a remarkable pediatrician, a remarkable doctor. All the people who know him or knew him, it was said he did everything so fast in his life. And, he took charge of the COVID committee, doing the organization and all the work, and he never stopped until the last day of his life. I can't move this. Let me see. Yeah, the third individual we're dedicating this to his memory is a surgeon from Ghana, from Accra. I don't know whether you know him, Lawrence. Dr. Kisa was a consultant surgeon, consultant general surgeon. Again, he lost his life at the age of 75. He was working until the last day, looking after his patients. He never again stopped, and he was one of the people who lost their lives to COVID. I sort of looked at these people to represent probably thousands of healthcare workers who lost their lives, in the front lines of duty. In Sudan, I know there are lots of colleagues from Sudan now. Not a single one of us, has not lost a friend or a family member from the healthcare setting to COVID-19. And, as I said, that was a wake-up call for everybody. And it really should be. Infectious diseases, particularly in Africa, you would remember probably, and probably Dorothy would know this, in the last Ebola virus in 2015 in West Africa wiped 23% of the healthcare workers there. So the numbers were absolutely staggering. Arif, can I move to the next slide, please? Just very quickly, let us have a quick look at the health workforce in Africa. This was from an article in the BMJ in 2022. There are 3.6 million healthcare workers in Africa. Probably Dorothy and David will know that. But interestingly, the projected shortage of the healthcare workers in Africa by 2030 is expected to be 6 million individuals. So the reason I'm saying these figures is, in occupational health, what we do is we look at, the hazards and the people who are exposed. So we're talking about almost 4 million people now. If you look, for example, in Africa for the oil and gas industry, which probably have the best healthcare, occupational healthcare in Africa, there wouldn't be anything like that number. So because these people are working in the healthcare sector, which is really not considered as the healthcare, that is why this actually happened. Healthcare workers everywhere are, in Africa, like everywhere in the world, are exposed to the same hazards. And anyone, in their first year of occupational health, you go through the hazards, the physical, the chemical and biological, and they are exposed to every one of those. Can you move my slide, please? I borrowed this slide from the WHO statistics from 2022. Dorothy would probably be the one who's done that. And you just have a look at that. 54% of healthcare workers in the low and middle income countries have latent tuberculosis. You just imagine that. If this is in any other workplace, this would make the workplace stand, upright to find a solution to that. And look at the statistic below. Almost, 80%, between 40 and 80% of nurses in Africa would have back pain. The violence, the COVID-19, we've spoken about that. But another very interesting thing in Africa, in particular for the healthcare workers, out of all of that, understaffing is a major, major problem. Each one of the people who are here, would go to the hospital or a clinic or wherever they work, and they probably be the only doctor there or the only nurse there, or, it would take a real, I do not know a single healthcare facility in all the countries in Africa I've been to, which is adequately staffed. Again, the insufficient supplies, we all see this, the infrastructure deficiencies. These three, in Africa are the main recipe for violence against healthcare workers. People, not enough people, not enough supplies, deficient infrastructure, lots of patients, and the frustration. And, can I move my slide, please? Maybe Hadir wants me to stop here. Right. I better stop here, and I would very much like to introduce my colleague, Dr. Dorothy Anangilu. I hope I've said your surname right. Okay. Dorothy is an occupational health specialist, a very rare breed in Africa. She works for the WHO. She is responsible for part of her responsibility is the health of the healthcare workers. We really are grateful for Dorothy's, contribution to this talk this evening. Welcome, Dorothy. The floor is yours.
Okay, thank you so much. You can see my slide?
Yes.
Okay, great. Thank you so much, Omar, for the invitation. And yeah, very grateful to be here today. and to speak about something, as you said before, that is I'm very passionate about, and that is very close to my heart. As you mentioned very well, that we're all medical, people, healthcare workers, health workers, and we come from families of health workers and their friends, colleagues who are health workers. So it's very important that we not only advocate for our own people, but also work to ensure that the health, safety, and well-being of health workers is safeguarded. So, yes. So it's no doubt that health workers are the backbone of health systems, but most often their health, safety, and well-being is overlooked. And this is no secret. That's why WHO, ILO, all development partners, all organizations are now speaking up, because we understand that if there are no health workers in the health systems, then the health systems collapse. And why is it important to protect health workers? First, it's the regulatory compliance. For many countries, there is legislation that mandates the protection of workers, and this includes health workers. And ILO last year declared health and safe working environment as a fundamental principle and right at work. And that means even health workers have the right to enjoy health and safe working environment. So it's not only the national laws, it's not only regulatory compliance for national laws, but also for the international regulations that health workers should be able to be protected and safeguarded in their working environment. The second reason why it's important to protect health workers is to ensure quality of care. When health workers are healthy and safe, it improves their productivity, increases the quality of care, and also the quality of care that they provide to the patient, and also the patient safety. Always say that patient safety and health worker safety are very well connected. When the working environment for the health worker is not safe, then the patients are also not safe. So when there's infection in the workplace, when there's violence in the workplace, when there is a chipped floor that anyone can be injured and fall, the patients can fall, and health workers can fall. So improving the health and safety of health workers directly improves the quality of care that they provide to the patients. The third reason why it's important is resilience. Protecting health workers increases the resilience of health systems in the face of outbreaks and public health emergencies. And we've seen this with COVID, and that countries that had mechanisms or had policies for protection of health workers were better prepared to care for the health workers and in a way keep the services going, as opposed to countries that didn't know anything. They didn't have occupational health and safety for health workers. So when COVID hit, they didn't know how to keep health workers working safely in the working environment. So this means that when you protect health workers, then it becomes easier when there's an emergency. Then the health system can respond very quickly. And lastly, it's important for stimulating the retention of the health workforce within the health sector. Dr. Omer mentioned very well that in Africa we have a huge shortage of health workforce, so we cannot afford to lose more. So health and safety of health workers makes sure that health workers stays in the health system instead of them doing something else entirely. So this is an outline of my presentation. I will highlight the challenges. Some of them we've already had, the opportunities for change, but also what is happening, some leadership in action that is happening already in Africa at the moment. So we understand COVID showed that health workers are important. We need to keep them health and safe. So if health workers in 2020 were in all front pages, you open your TV, you hear health workers, our heroes. We had very nice names. Some countries stopped everything at a certain hours of the day to just clap for the health workers and praise. These are heroes, kings, queens, all sorts of praises. And then COVID is, the pandemic is declared over, then health workers are now being forgotten. And this is the betrayal of our health heroes, that the people that we praised so much in 2020. And this is unacceptable. But this is not something new. We've had the same situation with the Ebola outbreak in West Africa. Again, health workers had all sorts of nice names, and then when Ebola outbreak was over, everyone forgets about these heroes that we loved and praised so much. And this is something that should not be happening. So the health sector is one of the most hazardous sector. We know about all the range of hazards that health workers are grappling with: infections, economics issues related to unsafe patient handling, chemicals, radiation, mental health, violence, the ambient environment risks such as noise, heat, etc., injuries, sleep, trips and falls, and also environmental health hazards. So WHO has a nice e-tool where all these hazards are summarized, and it includes the recommendations on what WHO and ILO recommends for these hazards. So this slide is just to mention that health workers are indeed in trouble in terms of hazards and risks. So some of this data has already been presented, so we cannot ignore these numbers. And these numbers call for urgent action for protection of health workers. So 41% of health workers are exposed to hepatitis B, C, and HIV, and this results in 12,000 cases of infection every year. Only 18%, less than 18% actually of health workers are vaccinated against hepatitis B, latent TB, as Dr. Omer has mentioned, and during the Ebola outbreak, up to 30, health workers had a risk of infection up to 30 times more than the general population. So this shows that when something happens, even if it's affecting the population, but for the health workers, for example, these infections are way higher than the general population. I think this is also the same case in COVID-19 pandemic as well. And during the first 17 months of the pandemic, over 100,000 health workers died from COVID-19, and this could be an underestimate. Chronic low back pain, mental health, suicide, depression, anxiety, insomnia. These are all issues that health workers are dealing with day to day. Violence in the health sector, highest in South Africa and Egypt, and this year WHO will issue a report on violence for health workers, and these numbers will be updated. So yes, so those are the big numbers about what are the risks, but we see that it also hits the economy as well. So data now is showing, for example, this research that was done to model the economic burden of COVID showed that one health worker infected with COVID-19 costs over 30,000 up to, over 30,000 US dollars for the health budget. So and this is research that is coming from Africa. So it shows that not protecting health workers, causes a huge burden for the economy as well. Because some of the arguments that countries usually bring, some countries bring, is that health workers are not bringing in any money to the in terms of economy. But when you see the amount of money that is lost by health workers not being in the workplace because of occupational issues, then that changes the narrative. I think in some other countries they term health work, for example, return to work as a positive outcome of healthcare. So that's another way of showing that health workers do bring in, I mean, when you care for the health worker, you are also protecting the economy in a way. So there are systemic challenges that exacerbate the health and safety of health workers. So not only the hazards that we see, the classical, but as Mr. Omer mentioned, the chronic understaffing, which leads to increased risk of burnout, errors and injuries, no social protection. Health workers in some countries do not have health insurance. So when a health worker get an occupational injury or just gets ill, they do not have access to health insurance. Now, I mean, the co-workers come in and have to chip in and pay out of pocket, something that is not it's not acceptable. There are no compensation for occupational injuries and diseases. Again, health worker sustains an injury or gets an occupational disease, then they have to pay out of pocket. And this you'll find happening in a country where there is oil and gas, or there is uh, um, mining, where something like this for the mine workers is, I mean, does not happen. So it's very interesting that up to now we still discuss about health of health workers as if it's something that we need to negotiate, whereas it should not be the case. There's lack of investment in health worker protection. So we do mention about the health workers not having enough health workers and chronic understaffing. In some countries where these issues about understaffing, in action, there are health workers every year. There's so many medical students graduating from this schools or nursing schools or lab school. I mean, schools, but there's no investment in terms of employing these health workers. So then it's also another issue. So there's no investment in creating posts, investment in providing essential resources for safe work, including personal protective equipment, and that compromises the health worker health and safety, as well as patient safety directly. So those are the challenges. It's a range of challenges. They not only threaten their health and safety, but also the sustainability of the health system. Now, what are the opportunities for change? So in 2022, WHO and ILO issued a guide on development and implementation of occupational health and safety programs for health workers. And in this guide, WHO and ILO recommends that occupational health and safety of health workers needs to be upscaled. And this involves the development and implementation of occupational health programs at all levels, from the national, sub-national, and facility levels. And this, what does this entail? It entails introducing new and updating existing regulations. So for most countries, especially in Africa, occupational health and safety legislation is an old legislation, for example, that does not cover the health sector or the services sector. So mainly it's an old Factories Act that was from the colonial era that covers factories, or in some areas it's only covering the mines. So health workers are completely out of the regulations. So it's important that these regulations are updated to ensure that health workers are protected. So for those, but there are some countries that do not have any legislation. So it's important that the new legislations are introduced to ensure that there is adequate protection of health workers, and also to ensure that health and safety of health workers is part and parcel of the management of healthcare at all levels, and to ensure that health workers have access to competent occupational health services. And one important factor is the synergies between occupational health programs and other programs and other stakeholders within the health system and also outside the health system. So based on examples from different countries, what these programs look like. So the guide provides guidance on what are the key elements, but also guidance on how these programs can be developed. And based on these examples from different countries, these are the key elements of these programs. So they're divided into four main pillars. So government and stewardship, financing, human resources, service delivery. So it's important that it's a national policy statement on occupational health for health workers, and this is from the Ministry of Health, because for majority of people, the Ministry of Health is the employer of the health workers. So since the legislation mandates that the employer makes sure that the health and safety of its workers is safeguarded, so the national policy statement on occupational health of health workers needs to come from the health ministry, showing political commitment at the highest level that the Ministry of Health cares for its workers. There has to be a personal unit in charge, so there has to be someone who can spearhead or take charge of this program within the Ministry of Health. And there has to be a multi-stakeholder national steering committee to take lead of this program and advise the personal unit in charge of occupational health and safety. There has to be regulations and standards, information and research, so everything is evidence-based. Then there has to be mechanism for efficient financing of occupational health measures. Like I said, there is lack of financing, so it's important that there is financing from the health budget that is dedicated to occupational health and safety of health workers, because we understand when the health workers are within the health systems, then the system is resilient and the patients are taken care of. So there has to be adequate human resources for occupational health and safety. So the whole breadth of occupational health, occupational physicians, occupational nurses, hygienists, psychologists, etc. Adequate supplies and commodities for occupational health are available. Services, not only the occupational services, but also services for TB, HIV, and hepatitis as the main occupational infections. So then that is what needs to happen at the national level. So then when you come to the facility level, there has to be a facility policy. Carries different names depending on different countries. So some countries call it a memo, some call it a facility policy. But what is important is that at the facility level, the facility manager writes something and has a document to say that they care and they have actions for protecting health workers, for appointing a facility focal point for occupational health and safety. So this will be a counterpart of the person in charge within the ministries. So that will be the counterpart within the facility at the facility level. Then regular risk assessment to identify hazards and put control measures, establishing a joint labor management committee within the facility, so that this will hold the management accountable in terms of health and safety of health workers, providing facility for personal hygiene, a training program, occupational services from early detection, diagnosis, treatment, care, and support for occupational injuries and diseases, provision of immunization for vaccine preventable diseases, and this should be at no cost to the health workers. At the moment, there's countries that provide immunization, for example, for hepatitis B, but health workers have to pay out of pocket. So this shouldn't be the case. Health workers should be immunized, and WHO provides a list of recommended vaccines that health workers should be immunized against. So that's important that this is provided free of charge for the health workers. Recording, investigation, and reporting of incidents, and also collecting and analyzing data from the facility so this data can inform the program. So this is what WHO and ILO recommends: policy reform, workplace intervention, and this has the potential to transform challenges into opportunities for healthier and more resilient workplaces. So let's look at the third and final part of my presentation, which is the leadership and action. So at the moment, globally, only 1/3 of countries have some national health policy instrument for protection of health workers. And what we see in Africa is actually taking lead in terms of countries that have these programs. So at the moment, we have WHO monitors through an indicator within the Global Health Observatory, an indicator on the existence of national policy instrument for occupational health of health workers. And at the moment, 8 countries have such programs. So Tanzania, Kenya, Uganda, South Africa, Malawi, Togo, Ghana, and the Gambia. And these countries are at different levels of having the program. So some have a policy that's been signed but has not been implemented, and some have started implementation at different levels. So these are the countries that are showing are leading, and there are some countries are actually currently in the final stages of developing their policies. I think Botswana, Eritrea, these are some of the countries that, and Sierra Leone, I think, are in the final stages of getting the policy signed and then starting with the implementation. And when you look at these countries, these are the 4 key factors that led to their success, I would say, in having a policy and being at different level of implementation. First is the political commitment at the highest level. So the minister is on board and saying that they care about the health workers and they put in the political commitment to action. Then there's collaboration. So Minister of Health, Minister of Labor, labor unions, professional associations of health workers, non-government organization health workers. So there is collaboration, and that is helping quite a lot in terms of development, but also the implementation of these programs. And another thing that is also very, very key is there is an earmarked budget allocation for health worker protection within the Ministry of Health. And this is very important because there is, like the 4th point said, there is external technical and financial support, for example, from ILO, WHO, but then that can only last so much. So when countries have an earmarked budget allocation for health workers within the budget, the Health Ministry of Health budget, then it means these programs are consistent and they, sustainable, because even when the donor is not there anymore, then the work continues. So the investment in health and well-being is a sound business decision, and this is coming from countries. And globally, it shows that improving health and safety of health workers first lowers the cost of occupational harm, which is estimated up to 2% of health spending. And it also contributes to minimizing patient harm, which is also it's 12% of health spending. So these are some of the arguments that we need to bring to our political leaders, that protection of health workers is not a loss. It's actually saving, or it's saving the budget, the healthcare budget. So what we've seen in countries, so this is a case study from Tanzania that shows what has been happening since the program started. So the history of Tanzania is the policy guideline development started around 2016. And then at around 2019, that's when the policy guidelines were signed by the minister and then they were issued. So you can see, from 2016, there were meetings, there were workshops here and there, and so just to get the policy developed and then signed. So from the time when the process started, you could see there was improvement in terms of the indicators, and these are the indicators from the National Health Management data. And it showed that after the policy was issued, there was an increase in hepatitis B vaccine uptake for the health workers. There was increased coverage for post-exposure prophylaxis for HIV, and also improved reporting of cases of violence against health workers. So these are some of the indicators that countries are showing that when measures are put in the health system for protection of health workers, there is good results in terms of health outcomes for the health workers. So this brings me to the end of my presentation, where I highlighted the challenges that the health workers face, risks that threaten their health and safety, but also the sustainability of health systems. There's opportunity for change in terms of policy transformation and also interventions at the health facility level. But Africa, countries in Africa are demonstrating leadership in terms of health protections. And these are some of the success stories that I've shared from these countries. So if you'd like to learn more about how to protect health workers and what WHO and ILO says in terms of health and safety of health workers, there's an e-tool that I mentioned in the beginning of my presentation, which has what are the hazards and then what WHO and ILO recommends. We have a manual on public health emergencies for protection of health workers during public health emergencies, and this is not just communicable disease outbreak, but also all sorts of emergencies, not only the communicable diseases. We have a policy brief on national programs, checklists for healthcare facilities, where facilities can use it to identify and prioritize areas of action for improving protection of health workers. And we also have an open WHO course on occupational health and safety of health workers. It says in the context of COVID-19, but it has more general messages on protection of health workers, not just in the context of COVID-19. Thank you, and that brings me to the end of my presentation.
Thank you very much, Dorothy. Thank you so much. That's a really, really wonderful insight. And, there are particularly very, very helpful bits for our young colleagues who are in training in occupational medicine. I think if they follow some of that, presentation, they will do very, 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 very well. Thank you very, very much, Dorothy. And just before I introduce our second speaker, I just saw in the attendance Professor Gassana, who has managed to actually join the meeting. So a very special welcome to him. Professor Gassana is one of the pillars of occupational health in Africa. He is based in somewhere very, very, very pleasant and nice in Florida in the USA now. And I'm sure it's very early, but thank you very much, Professor Gassana, for making the time and the effort to be here. Our next speaker is a truly remarkable young man, Dr. Omar. I was telling my colleagues in the panel earlier that the first time I came across Dr. Omar is when he put just a very small brief post on LinkedIn on research he did in the Sudan about sudden death in young Sudanese doctors, which was quite shocking, actually, just looking at the title of the research. So I got in touch with him, and we've been talking about that. Dr. Omar is a physician. He trained in Sudan. He never left Sudan until Sudan as it's currently being systematically destroyed. He's got his MD, so he's fully qualified. And at such a young age, I was just so surprised to read in his bio that he actually has written a book about the common emergencies in the Sudan. Honestly, when you see young people like Omar, just tackling so many things there, and I sincerely would hope that, especially our panelists will encourage people like Dr. Omar to venture into the health of the healthcare workers. Thank you very much, Dr. Omar. The floor is yours. We lost Dr. Omar. We seem to have lost Dr. Omar for a reason. Let me ask him to unmute.
Thank you, Dr. Omar.
Oh, they are.
Okay. I have difficulty in sharing my.
Yeah. Are you able to share your presentation?
Yeah.
Okay. So just click on share, and it should. I think you are a co-host, so you should be able to share. Hello. I'll see if Dr. Hadir can help Omar.
Looks like we're not hearing from him. He's muted.
Can you share it, Hadir?
Sorry, Omar. Hadir and the technical team are having some difficulties with the presentation. So let me introduce Lawrence and keep going, and we will get to you once that is sorted from that end. Dr. Lawrence, where is Lawrence? Yes, I can see Lawrence
I'm here.
there. Dr. Lawrence is a consultant occupational physician. We trained together. We did our exams together, and just before we started, I think it was 20 years ago when we first touched base together. Lawrence is a senior consultant in occupational medicine. Since I've known Lawrence, he has been interested in working with healthcare workers in the UK, in the NHS. He is the one, he really is an authority in exposure injuries, needle stick injuries, in tuberculosis, HIV, and all the nasty things Dorothy spoke about earlier. Lawrence is really passionate about education as well, and I've seen him, speak and teach quite a lot. He is a true African as well from Ghana. And yeah, I better not say more. Uh, all to you, Lawrence.
Oh, brilliant. Thank you very much, Omar, for that introduction. So can everyone, hopefully my screen is being shared, yeah?
Yeah.
Okay, so I'm going to go into my slideshow, yeah, hopefully, yeah. Okay, right, so I'm going to talk about the management of needle stick injuries in healthcare workers. And I'm based in the UK, so I'm a consultant in the UK. I work both in the NHS and in the private sector, so I cover quite a few private hospitals as well as NHS hospitals. So this is really the UK approach, but I expect the principles are probably going to be the same around the world. So what I'll do is have some background information, and then I'll talk about the management of an exposure incident. In the context of this presentation, when I say exposure incident, especially in the UK, when we talk about an exposure incident, what we talk about is either a needle stick injury or a splash injury into the eyes or nose or mouth. And then I'll focus on HIV prophylaxis, in particular, conducting a risk assessment for HIV prophylaxis. I'll talk about hepatitis B and also hepatitis C. So the three main blood-borne viruses that we worry about, certainly in the UK, and the three that I'm going to focus on are HIV, hepatitis B, and hepatitis C. Obviously, there are other blood-borne viruses, such as malaria, and in other bits of the world, there's certainly in Africa, there's Ebola, and more recently in the UK, HTLV1, so the human T-cell lymphotropic viruses are something that is around. So in the UK, since 1997, there have been 5 documented cases of occupationally acquired HIV, and there's been one fatality. There have been 21 cases of hepatitis C. There have been no hepatitis B transmissions for over 10 years. So it's interesting to hear Dorothy's talk, and 18% of healthcare workers in Africa being vaccinated against hepatitis B. In the UK, the reason that we've probably not had any transmission is for healthcare workers, there is a vaccination program. So all healthcare workers have to be vaccinated, and it's actually not at cost to the health worker as well. So certainly hepatitis B is one of those vaccine preventable diseases that in the UK, we haven't seen any hep B transmissions for over 10 years. Right, so in terms of HIV, the risk of seroconversion following a exposure incident, and when a percutaneous exposure is blood, so that's needle stick injury or a sharp injury, and this is where you've got blood from an infected source into an artery or vein. The risk of seroconversion or transmission is 0.3%. That's 3 in 1,000. With mucocutaneous exposure, so that's blood from an infected source or high-risk body fluid, splash injury in someone's eyes or mouth or nose, the risk of seroconversion is 0.1% and 1 in 1,000. So there's evidence from a case control study, and this is done by CDC many years ago, and that study actually identified 4 risk factors for seroconversion following an occupational exposure to HIV. And in that study, they showed that given AZT actually reduced the risk of seroconversion by 80%. So the 4 risk factors were if the source patient had a terminal HIV-related illness, if the injury was a deep injury, if there was visible blood on the device which caused the injury, and if it is a needle, if that needle had actually gone and been placed into a patient's artery or vein. And this is in contrast to, say, an IM injection. So in most cases, seroconversion will occur within 12 weeks. There is evidence from studies in primary HIV infection which show that viral dissemination doesn't actually occur straight away. So there is this window of opportunity when you can actually prescribe PEP in that early stage. So for hepatitis B, risk of seroconversion very, very high, 30%. And as I said before, and that's in the unvaccinated. So if you're not vaccinated against hepatitis B, then there's a very, very high risk of seroconversion if you do have a needle stick injury. And for hepatitis C, risk of seroconversion, following a sharp injury, between 4.04% and 1.8%. So this is just data from Public Health England, and this is data that was collated between 2004 and 2013. Most exposures were to hepatitis C, so 54%, and these are to HIV was 30%, and co-infections were 7%. And the same report showed that most exposures were to sharp, so 71%, and of most of the sharp injuries, most of them were from hollow bore needles, so 65%. And in terms of the group to sustain exposure incidents, so needle stick injuries, plus injuries, doctors and nurses top the group. So that's the doctors and nurses at the top, as you can see. So this shows list of high-risk body fluids. Exposure to blood is the most commonest, but other high-risk body fluids include pleural fluid, breast milk, amniotic fluid, and peritoneal fluid. Urine, feces, saliva, sputum, vomit, these are generally not regarded as high-risk body fluids unless they are visibly blood-stained. So, as I said, in the UK, exposure incident, so this is a generally accepted definition. So it's exposure to blood or body fluid from a patient through broken skin or mucous membrane contact. And this can be free from a needle stick injury, from a sharp injury, or blood onto a cut that's not being covered with a waterproof dressing, or onto broken skin, such as if someone's got eczema, which is active, or blood or body fluid into a mucous membrane, so splash injury into someone's eyes or mouth. Generally, if the skin is intact, then you've got a high-risk body fluid or blood onto that skin. That is generally not regarded as an exposure incident, and the healthcare worker can usually be reassured. So, in terms of managing an exposure incident, risk assessment, so occupational health, in terms of occupational health risk assessment, so we all know about risk assessment. So the risk assessment approach. So the initial risk assessment is to determine the type of exposure. So if it's a sharp injury, if it's a needle, is it a hollow bore or a solid bore? And importance of whether or not it's a hollow bore needle is usually, I'd mentioned about the device being bloodstained. However, the hollow bore needle, there's a risk of actually having quite a high amount of blood actually in the bore of the needle. So again, then the dose of exposure is much higher, increased risk of conversion versus just a needle that's not a solid bore. So maybe, I don't know, suture needle or yeah. So is it a mucocutaneous exposure? So is it into the eyes, nose, or mouth? Or is it an exposure onto broken skin and that is not covered by a waterproof dressing? The next thing that we then determine is the type of fluid that the individual has been exposed to. So is it either blood or one of the high-risk body fluids? What personal protective equipment was the healthcare worker wearing? Gloves, or do they have eye protection if it's a splash injury? Now, in terms of gloves, that's quite important, actually. And there is evidence that with needle stick injuries, a lot of the blood, up to 80% of the blood, is actually wiped off when the needle goes through the individual's glove. So again, that reduces the risk of seroconversion. And then the next thing is to determine what first aid measures were implemented. The general advice is to encourage bleeding, to wash the wound with soap and water, and to to actually cover the wound with a waterproof dressing. If it's an exposure into someone's eyes, then it's to irrigate their eyes with water. If the person is a contact lens wearer, then to actually irrigate before removing the contact lenses and then after removing the contact lenses. Healthcare workers are advised not to scrub or sack the wound. The next thing then is the source patient known? If the source patient is known, do they have any, is their bloodborne virus status known, or do they have any high risk factors for having a bloodborne virus infection? In the hospital setting, the clinical team will usually be asked to approach the source patient to take a history and ask about any risk factors, and consent that the source patient to actually test for bloodborne viruses. In the UK, the general guidance from the Department of Health is that hospitals should actually have a facility to test within 24 hours. What about me? How do I got to? Right. So in terms of source patient testing, clinical team usually either middle grade doctor or a senior medical senior nurse will be asked to approach the source patient for obtain their consent to be tested for the 3 bloodborne viruses, and the source patient is informed. What about, I think my slides have gone, something's happened, hang on. Why have I? I think I have made, sorry. Yeah, so I think I've gone. Yeah, so this is for the healthcare worker. So this is for the actual healthcare worker. Normally would discuss the risk of seroconversion with the healthcare worker, and so I go through those the risks for the 3 bloodborne viruses. If the individual is wearing gloves, we'll explain to them about the fact that having gloves would have actually reduced your risk. We need to know about the hepatitis B vaccination status of the healthcare worker, and also in the UK, a blood sample is taken for serum save, and with the serum save sample, the sample is not tested, but it's saved for 2 years, and in the unlikely event of the healthcare worker actually testing positive in the future, you can actually go back and test that sample to make sure that the healthcare worker didn't have a bloodborne virus at the time of the incident. As I said before, we are paying the source patient's consent to be tested for bloodborne viruses, and usually a member of the clinical team, the middle grade. Important that it's not the healthcare worker who's been exposed, and the bloodborne viruses that we test. Also, we do HIV 1 and 2 antibodies, hepatitis B surface antigen, and hepatitis C antibodies. And as I said, the hospitals should have the capacity to actually give a result within 24 hours. So pre-test discussion with the source patient, they informed about the incident, give them the explanation as to the reason for the test, and also importantly, who will the test be disclosed to, so to the occupational health team, and also to the staff member. Where possible, we try as much as possible not to disclose the staff member's identity. So now put here HIV post-exposure prophylaxis. So this really is to decide whether or not to start PEP while we're waiting for that source patient's result. So in terms of deciding, do we start PEP if it's a high-risk injury? So first of all, we need to determine, was the injury significant? And what was the exposure to? So what high-risk body fluid? Was it a high-risk body fluid exposure? And was it blood? I know I said saliva is not regarded as high risk unless it's visibly blood stained. However, if it's saliva associated with dentistry, then that is regarded as a high risk body fluid, as it's likely to be contaminated with blood, even though if it's not visibly blood stained. Then the next bit is, do we know the HIV, the source patient HIV status, or does the source patient have any high risk factors? So if the injury was significant, or if the source patient is known to be HIV positive, a significant injury, known to be HIV positive, or has high risk factors for HIV, then we will actually start post-exposure prophylaxis before we get that result, the blood test results, and we can always stop HIV and the PEP prophylaxis if the source patient then subsequently tests negative. These are the drugs that we use, so Tafida and Matrigravir, normally prescribe an antiepileptic as well. And as I said before, there is that CDC study which showed that given AZT actually reduces the risk of seroconversion by 80%. So when I first started out, and that's mainly, as Emma said, over 20 years ago, when I probably more than that, that's too long. So as a registrar, when I first started out, we would prescribe HIV prophylaxis. It's taken for 4 weeks. Subsequent guidance came out, and this was released by the British HIV Association. And if a source patient is known to be HIV positive on treatment and undetectable, then there's no need to prescribe PEP. So that the guidance changed. So if the source patient is known to be HIV positive and their viral load is undetectable, then the risk of seroconversion is next to nothing. And we generally do not prescribe PEP in those circumstances. So there is some evidence that PEP is most effective. It's started within an hour. In most cases, it started within 24 hours. There's very, very limited evidence that it works. It started after 72 hours. And in the UK, if PEP is started under 72 hours, then this is only done in agreement with an HIV consultant, an occupational health consultant, and a microbiologist. So this is, again, Public Health England data, and this is data looking at 1,478 cases where the source patient was known to be HIV positive. So in 51% of cases, PEP was started with less than 72 hours. In 2% of cases, it was over 72 hours, and in the other cases, it wasn't reported. So pregnancy is not a contraindication to prescribing PEP, but it may affect which choice of drugs that you prescribe. Certainly, from my perspective, if someone is pregnant, then I'll be speaking to an HIV specialist, and anyone who's prescribing PEP should actually have the facility to do a pregnancy test if necessary. This is a list of some of the drug interactions. There are a number of references that you can go to. So the Liverpool HIV Pharmacology Group, and that's their web address at the bottom, have information on drug interactions. We've got the British National Formulary, and also the summary of product characteristics of the drug that I saw. Need to consider drug resistance. Certainly in the UK, if the source patient is known to be HIV positive, then they would have had drug resistance testing. And if there's any resistance to any of the drugs that are being prescribed as part of PEP, then again, an alternative regime needs to be prescribed, and I'll be speaking to an HIV specialist. So this is a list of some of the side effects: nausea, vomiting, diarrhea. And certainly in my time of managing needle stick injuries, some people can be very, very unwell with the drugs. And sometimes people are, the healthcare worker has to take time off. And I've known that healthcare workers take the whole 4 weeks off while they've been on treatment because they've been so unwell. So bloods are done. And again, when I first started out, we would see the healthcare worker on a weekly basis. Then we'd do all these bloods, guidance released to do initial baseline bloods. And if these bloods are normal, then no need to do any further blood tests. So the individual doesn't need to keep coming back to the occupational health department. Right, so for hepatitis B, if the individual is previously immunized and they have a needle stick injury or an exposure incident, would normally give a Hep B vaccine booster dose. If the individual is a known non-responder to vaccination, then hepatitis B immunoglobulin will be considered. If the individual has no previous history of vaccination, then two options available are either to give immunoglobulin or an accelerated course. And the recommendation for the accelerated course is 0, 1, and 2 months. However, it can be given at 0, 7, and 21 days. So this is a publication in the UK, and it's generally referred to as the Green Book. And in the Green Book, there's a brilliant chart which actually has all the different scenarios for hepatitis B exposures and what to do. So it's a brilliant reference point. So for hepatitis C, there's no post-exposure prophylaxis. However, there is evidence that those who are going to seroconvert following an exposure to hepatitis C, and this is an exposure incident, a needle stick or glass injury, will do so within 15 days of the injury. There is good evidence that if the individual seroconverts and if they receive antiviral treatment within 12 weeks, then 96 to 98% of those will actually clear the virus, so totally clear the virus. Testing regime is 6 weeks, 3 months, and 6 months. And I normally advise healthcare workers on the importance really of attending that 6-week appointment. If the individual has any type of seroconversion like illness before their first 6-week appointment, then we would test them straight away. And this is just a slide that tries to put everything together. So, is there an injury a high-risk incident? Was the individual exposed to a high-risk body fluid? Is the source known to have a BBV, or are they high risk for a BBV? And certainly when we look at HIV, then you make the decision to prescribe PEP. Individual is serum safe, so sample taken serum safe for 2 years, and important in terms of the individual's hepatitis D status. These are the follow-up blood tests that we do or that are recommended. Again, when I first started out with HIV, we'll do testing at 6 weeks. Guidance came out saying no point to do that test at 6 weeks, just do it at 12 weeks. You do it 6 weeks if the individual is very anxious, but you still have to repeat it again at 12 weeks. If the source patient is unknown, then we just do blood at 12 weeks. And then we've got a protocol again for hepatitis C and hepatitis D. So in terms of the healthcare worker, important to, when they have their follow-up blood, actually discuss with them, and this is a list of the questions, or they're not questions, but things that we go through with the healthcare worker. So normally, do they understand the meaning of the test? What are we testing for? Some discussion about the methods of transmission, the risks of seroconversion that I went through earlier, and also how would the person react in the unlikely event of that test being positive? Who would they tell? What's their support network? Important to inform them of when the results will be given. So when are they going to be available and by whom? And how they're going to cope while waiting for those results. If appropriate, to give the individual your contact number they can ring, and we ask the individual to just a documentation of occupational records that we've had that discussion, and that the individual signs a consent form. But I put this really to remind me just to talk about the sort of psychological fallout following needle stick injuries. So certainly in my practice, the amount of stress and that the healthcare worker is under really, when they have a needle stick injury, but also in that waiting period as well for their test results in terms of their follow-up blood test results. So this was a case control study. It was in 2009, and it looked just at needle stick injuries. And what they found was that there was a high rates of depression, so increased rates of depression. There were a small number of cases that had symptoms consistent with a diagnosis of PTSD, and what they also found is that the symptoms actually got better over time. The recommendations out of that study was important to arrange prompt follow-up blood testing, and there was some evidence that if healthcare workers had prompt testing, that would actually reduce the duration of any depression or stress associated with needle stick injuries. And I think that is a quick tour through needle stick injuries.
Thank you very, very much, Lawrence. Thank you so much. That really is, it's very interesting and very, very educational. If I may just say two things to our young colleagues, especially those who are taking exams, it is very unlikely you go through your training in occupational medicine and you're not asked about, the risk assessment of a needle stick injury. We'll ask Lawrence later whether we can share his slides with young colleagues. The other thing, the important thing, if you join occupational health, you eliminate the risk completely. So you're not going to use needles, and the chances of a needle stick injury is probably very, very, very low. Thank you very much, Lawrence. Thank you. Have we managed to sort out Dr. Omar's presentation?
Hello, Dr. Omar.
Hi, hello.
Excellent.
So we've got Dr. Omar's presentation up now eventually. Thank you very much, Dr. Omar. Yeah. This floor is all yours.
Thank you, Dr. Omar. I am very happy to join this webinar. Today, I would like to present my paper about sudden death among young Sudanese doctors, a wake-up call. Hadir, you can move. Okay. The agenda of this presentation, firstly, I will there is brief introduction, possible causes, intervention, and is this issue limited to Sudan only? Okay. In recent years, there has been a noticeable increase in rate of sudden deaths among young Sudanese doctors. Currently, there are no official reports, previous studies, or statistics regarding the number of deaths or their causes. A common link among the cases is that most of the affected are early career doctors in highly demanding specialties with significant physical exertion. Regarding the causes, there is a lot of causes. One of them is karushi. The term karushi, or death due to overwork, is a Japanese term for the phenomenon of sudden death resulting from working long hours under immense pressure, combined by stress that can lead to heart attacks, stroke, or depression that enhances suicidal tendencies. It is important to note that shift in Sudan can sometimes extend beyond 24 hours. In recent years, social media has been filled with news of deaths of many doctors after shifts that lasted more than 36 hours. The hashtag Stop the 24-hour shift has trended on Sudanese social media following these sudden deaths. Low salaries. Low salaries lead to dual employment between government and private hospitals for long periods to support families and meet familiar responsibilities, alongside continuing postgraduate studies, which result in psychological and physical exhaustion. Burnout syndrome. Burnout syndrome is a combination of severe physical and psychological fatigue experienced due to increasing work pressure, potentially leading to sudden death from cardiac arrest. The main cause of burnout among doctors is high psychological pressure, combined by a strong sense of commitment to rules and high ideals, making doctors feel like failures when when they do not achieve the required standards in their minds or those demanded by society and the system. Regarding the work environment, Sudanese doctors face very poor working conditions in hospitals, lack of comfortable rooms, absence of meals and drinking water during shifts that can extend beyond 24 hours. Neglecting routine medical checkups. Many Sudanese doctors neglect regular medical checkups. These checkups are crucial for the early detection of diseases such as pre-diabetes, diabetes, and hypertension. Absence of pre-internship and specialty medical checkup. The importance of this examination lies in the early detection of diseases that may lead to sudden death, such as electrical heart disease and cardiomyopathy. Doctors with this condition can advise to avoid physical demanding specialties like surgery, obstetric and gynecology, and emergency medicine. Neglect exercise and smoking. Due to work pressure and low salaries, leading to long periods of dual employment between government and private hospitals, Sudanese doctors neglect exercise. Additionally, work pressure correlates with increased smoking rates among young doctors. Lack of protective legalization. 1 out of every 2 Sudanese doctors face violence at some point of time in their life, whether it was physical, psychological, or both. The absence of protective measures expose Sudanese doctors to physical and verbal violence during their work. Anxiety about legal responsibilities and frequent attacks from patients and their families place doctors under very high psychological pressure. The ongoing conflict in Sudan. Personality safety. Many of doctors becoming target of violence. During the last months, we have lost 7 doctors in Sudan due to ongoing conflict. The seven doctors, the cause of this is target of violence. Mental health strain, the destruction of health care facilities and displacement of population have led to overwhelming of workload for the remaining medical personnel. Long hours, lack of resources, and emotional stress contribute to high level of burnout. Suicide. There are no statistics on the number of suicide cases among Sudanese doctors. From my observation, there have been 3 cases of suicide among young Sudanese doctors in the last 2 years. The 3 cases, 2 of them are my colleagues. Additionally, there are numerous messages in the Sudanese medical groups on the social media related to desire to commit suicide. Interventions. Improve work conditions. Accurate regulation need to be established to define the maximum weekly and continuous working hours, including shifts, based on models from other countries. Optimize workflow and adequate staffing. Improving salaries. improving the financial condition of young Sudanese doctors is the only solution to prevent young doctors from working in more than one hospital per day at the expense of their rest and health. Fighting burnout offers workshop on burnout prevention, provide access to confidential mental health services, and stress management program for Sudanese doctors. Educate Sudanese doctors about the tips to decrease burnout, such as productive work, learning and practicing activities other than medicine, teaching others, whether in medicine or other fields. Sudanese doctors should adopt a healthy lifestyle, stop smoking, and maintain a healthy weight. Laws protecting medical personnel need to be activated, and media should help to improve the working environment and restabilize patient-physician trust, which may further decrease the sense of burnout for physicians. Is this issue limited to Sudan? In Egypt, the death rate among young doctors has increased in recent years, with two doctors dying monthly in 2022, compared to 3 deaths in all of 2018, even 11 in 2019, 7 in 2020, and 10 in 2021. Leading to health minister being questions in the parliament about the rising death rate among young doctors. Since the start of 2023, not a week has passed without a new death among young doctors being recorded. In Libya, the number of sudden deaths among young doctors, especially anesthesiologists, has also increased, prompting the Libyan Minister of Health to form an investigative committee. The committee concluded that the primary cause was long working hours, exceeding internationally recommended 35 hours per week, with some doctors were working between 42 and 72 hours weekly, in addition to taking some painkillers that allow them to work longer hours. The icon of suffering. This picture has become an icon of suffering of junior doctors in Sudan. It shows 3 interns doctors sleeping in one of the clinics after shifts that lasted for 24 hours. This is my paper, which published in the Journal of Annals of Medicine and Surgery, which discuss causes and intervention to decrease this the rate of sudden death among young Sudanese doctors. Any questions?
Thank you very, very much, Dr. Omar. Thank you very much. This is really disturbing. Honestly, this is frightening and disturbing. And I think it just makes it, also important that, what we're talking about today is not just talking. Honestly, we all know there are problems. I think this is just something that is thrown right in your face, and you just cannot escape it. Thank you very, very much, Dr. Omar. I believe there would be lots of questions for Dorothy, Omar, and Lawrence. We would leave that either to go through the the notes, if people can write, and Hadir and the colleagues can highlight the questions. But I think we need to get to, we have spoken about lots of issues now. Dorothy has eloquently highlighted all the real health issues that healthcare workers in Africa are faced with. Lawrence has shared with us the experience of the National Health Service in managing exposure injuries. and Dr. Omar has just presented this, honestly, really alarming issue within young Sudanese doctors. I would introduce Dr. David Okello to introduce our panel. David, we really are very lucky to work with David. David is, again, one of the pillars of health in Africa. He's got an experience of more than 40 years. He looks much younger than that. He must have, finished his medical school much younger. But David has a wealth of experience working, in various African countries within the WHO. He's currently the executive director of the African Center for Global Health and Social Transformation. He is based in Uganda, in Kampala, and David has been working, really closely with us in all the issues that are, we feel are very important to us in Africa. The two main issues that we've been talking about since we met in November, the health of the healthcare workers and the health of the individuals working in the artisanal and small-scale mining. To join our speakers in the panel is Dr. Hiba. Dr. Hiba Omar is the president of the Sudanese Doctors Union. I hope Hiba is here with us today. Unfortunately, Dr. Atim has not been able to join us today. Atim is the director of primary health care from the Ministry of Health in South Sudan, but unfortunately hasn't been able to join. Is Dr. Hiba with us? Hadir?
Yeah, Dr. Hiba is here, but she's facing some difficulties, but she's here.
She probably would have some technical difficulties, but David, can I hand you the panel, please? Can I ask you to unmute, David, please?
Yes, I have done so. I was thanking you very much. I'm thrilled by what I'm hearing this evening. The presentations have been very, in my view, very good. Well presented. The issues have come up very well. The panel discussion, probably they just summarize the take-home message, particularly for the audience in Africa. What should we take home from your experiences? I will start with Dorothy. Dorothy, you spoke very well about what ILO and WHO is doing, and you're working in a very strategic position in WHO. Yes, I heard your story about policy instruments have been put in place in a number of countries for occupational health and so on. But my big problem is implementation of those policies. It is really a problem. People will come and tell you we have a policy, we have instruments, we have a program, but implementation is very weak. We have a serious problem of understaffing. Many of our health facilities are understaffed, and all those problems that have been described, needle stick injuries and so on, will happen if you are understaffed. The issue of low salary is a big problem in Africa. People are not, we feel like health workers are not properly prioritized. We feel like they're not properly cared for. And even the public does not give them the kind of support they need, compassion, caring, and being kind to health workers. So they are like any other worker you find in the field. So there is a problem. So maybe, Dorothy, summarize what you have said in terms of policy instruments. Are they really being implemented? I know WHO is very good in developing policy papers, but implementation worries me. Dorothy.
Yeah, definitely. I agree with you. The role of WHO, yes, is to support countries to develop these policies. And yeah, but you are very right. The implementation is a big problem. And even like I showed there, some countries that do have policies, like I mentioned, not all of them. Some of them, the policy is just there. It has not been implemented, and some are in various stages of implementation. But in my opinion, I think the main issue is the political commitment. And what we see in the health sector, for example, is I mean, you might find a health minister who's very well committed to health and safety of health workers and trying to do everything. But we know in our current system in Africa, the ministers change very often. So you find somebody else comes and the priorities are quite different. And it needs really that collaboration between the health sector, but also other people, the professional associations and everyone to come together and continue this dialogue to ensure that this issue stays on top of the political commitment. The issue is, again, the implementation needs funding. So there has to be political commitment, not just saying, oh, we care, but it has to show in the budget that we do care, we need to employ more people, because some other countries, they complain, oh, we don't have doctors, but in my experience, some majority of countries in Africa do have I mean, people are not employed, like health workers who are working, selling stuff. They're not doing the work that they were trained to do because there are no posts. So it's important also to ensure that um, the employment of health workers, I mean, is prioritized, that investment. I see now there's investment in all sorts of things in healthcare, greening the health sector, reducing the carbon emissions in the health sector. There's lots of money that's going there, but what about health workers? So for me, I think political commitment, not just saying, but also showing in action that we care about health workers and putting what the politicians are saying into practice and implementing these policies. Yeah.
Well, that term political commitment, some politicians don't like it. They say we are fully committed. I think it's political intervention, which is usually not very strong. But Dorothy, sometimes we blame other people. I worry that even the healthcare workers don't care about themselves. You know, you have a colleague, you see them going down, they're going through a lot of stress, they are burnt out, but your colleagues don't talk about it. Can we also address this problem internally among the healthcare workers? What kind of policies can we put in place to encourage healthcare workers to look after their colleagues, their peers? I think that is missing.
Yes, no, absolutely. I totally agree with you, because I mean, all these policies and things that we can do nice, but the end user of all this intervention is the health worker. So the health workers need to have a say from the beginning. For example, when we speak about these programs that we advocate for countries to develop, we also say the health workers do have a responsibility as well in terms of their own health, but also the health of the other workers. So we do put the duty of care for the employer, be it the Minister of Health or the Minister of the Prime Minister, whatever. But then at the end of the day, we do have a requirement for health workers to take charge of their own health. You can do everything. You can provide all sorts of interventions, but if the health worker is not taken into account, it becomes useless. So they need to be able to be empowered to take care of their own health, but also be in charge of the health of the other health workers within the facilities.
You know, we have these professional associations across different disciplines. for doctors, for nurses, for paramedical staff.
Yeah.
I have not seen them spell out issues about, occupational health for themselves and enforcing it. They're the ones who should be highlighting these problems with the politicians, with the ministers. So professional associations, I think they have a responsibility to look after themselves.
Yes.
I think we should hit this head on. This is a very important issue.
Yes, no, absolutely. And I think the challenge as well, in terms of occupational health within the Ministry of Health, it's not like people don't care. Yes, there are places where maybe there are people that don't care, but for the majority, you don't find a Minister of Health or a permanent secretary saying, "Oh, I don't care." Sometimes it comes down to there are no people occupational health experts to support these people, to understand that these are the key issues and advocating for them. So us as occupational health specialists or people in the occupational health field need to collaborate with these professional associations to try and bring this issue to the surface. Because I mean, as health workers, people, I mean, we're given all sorts of name even when coming to the profession. You're told, oh, this is a calling. For example, when we were going to medical school, we are told, okay, this is a calling. Like you're going there. It's not about money. It's about you saving the nation. So that gets inculcated into your mind, and you're like, okay, I'm going there. I need to sacrifice my health so that I can take care of the nation. So we need to step back and also.
Absolutely.
And
well, Dorothy, any specific recommendation we can take? Omar and myself want to take this discussion to the next level. And I think the WHO plays a big role, and you can guide the ministries of health, listen to you. I think this is something, even in training, I have a feeling that sometimes training, we neglect these problems. People go to the field and they are faced with these very issues we are talking about. Any specific recommendation on implementation of those policies? Yes, the policies must be in place, but how do we monitor implementation?
Yes, so we do have, so WHO, I mean, in response to the guide that we developed, we do have a course on not only developing the policies, but also how they can be implemented for health workers. So we always looking for partners to work with, to be able to disseminate this and these courses are mainly targeted at people in the ministries of health or Ministry of Labor, so that we can provide the training. It's an online course, 3 hours that we provide, and we go through the process of what's the program, how is it developed, how it can be implemented, and all the strategies. So we can happily share with the community and get the message across to the countries.
Wow, Dorothy, I can't thank you enough. Please raise our flag there at headquarters.
Yes.
You are an important person. Occupational health is real. Look at the story from Sudan, from that young doctor. Omar did, those stories are very real, and they're not limited to Sudan.
Yes.
It's all over the place. And I think we should give it more attention. We should give more visibility to this problem.
Yes.
And thank you very much. Let me move on to Abiba. Is Abiba here?
Abiba.
Is Abiba able to talk, even if for a short time? If not, let me go to Lawrence. Lawrence, I like your discussion about needle prick and all the problems associated with it. This is real, and it's happening in the UK, but probably the story is much different from here. I think here it's a daily problem. I don't know what kind of lessons, what kind of advice do you give us in the third world who are facing this problem on a daily basis? The issue is not just HIV. COVID has been perhaps our biggest problem in terms of viral infection. And people are getting all kinds of problems because of COVID. all those other things you have discussed. Thank you very much. You are really, myself, I was very pleased with your very, very detailed description of what you are doing. So any advice you can give us to take to our people here in Africa?
Yeah. I mean, I think prevention of needle stick injuries is a big thing, really. So, if you can prevent them, then that is educating healthcare workers. What we find in the UK, and certainly when I was in training, we did some studies, and most needle stick injuries tended to occur at things like some sharp bin injuries occurred when the healthcare worker was disposing of the needles. So,
Yes.
so actually, we in the hospital I worked in, we brought in a policy, and the education of staff was dispose needles at the point of use. So not to sort of, so that's a simple thing really. So ensuring that if you taking blood or whatever you're doing, is to have your sharps bin actually close to you, so you're not actually going and a long distance to dispose of that needle. So I think staff education, wearing gloves, important. Like I said, 80% of the blood is wiped off. So straight away, and when I counsel people following a needle stick injury, if they're wearing gloves, one of the things I say to you, I go through the risk of seroconversion, but then I say, well, if you're wearing gloves, then we've actually reduced that by 80% because most of that blood has been wiped off. PPE, so gloves, but also eye protection as well. So depending on whatever procedure you're doing, if there's a risk of splash injury or splash exposure, then important that you have goggles on or a face mask. So I think that is definitely, yeah. So I think prevention, and if you do sustain a needle stick injury, then report it promptly, because if there is a risk of HIV, then the sooner we can start PEP, the better. So education in terms of using sharp, but also reporting injuries promptly. And I'm mindful that obviously the provision in different countries is going to be different, isn't it? So
Yeah, very different.
yeah, exactly. And then there's the cost implication, isn't it? So I suppose my experience as an occupational physician here in the UK is going to be very different to elsewhere in certain countries in Africa. So for me, someone comes in, needs a stick injury, there's not an issue in terms of prescribing post-exposure prophylaxis. Again, news to me, not surprising, but interesting that staff have to actually pay for their own hepatitis B immunization. So it's not just HIV we're talking about, but also hepatitis B. And if the hepatitis B vaccine is so effective, but
Yes.
the risk of seroconversion in the unvaccinated is so high as well, 30%, so almost 1 in 3. So again, is back to prevention, but also it's I suppose economic and finance in it really. So if people are expected to pay for their vaccinations, then that's going to reduce uptake, isn't it? And 18% is for me. I found that quite shocking, but not surprising.
Well, practice here is a bit different because a lot of times you don't even have PPEs. You have an outbreak of Ebola, you have an outbreak of COVID, and health workers do not have personal protective gears. And yet they're expected to go and work. They get exposed. They really get exposed. And then they go through this issue of stress, being worried about whether they have been infected or not. Or in theater, you're overworked. You worked for 24 hours. You're doing a cesarean section. Come on, you will get a needle prick, or even cut yourself, or even cut yourself in the process. So what you're talking about is real, and I think the notes you have provided are very useful. I would really encourage you to share these experiences with us. I think they will be very useful for our young doctors. I really appreciate your presentation. There may be questions that would follow. Let me finish with Omar, the young doctor from Sudan. Oh, my goodness. That was a very powerful presentation. And the old Omar should really thank you for making this presentation. All those things you were talking about, stress, low pay, people are depressed. Our doctors are stressed because they are very few in the field. And many times they're working 24 hours shifts, 36 hours shifts. During COVID, I know doctors who were isolated in facilities and they were not getting out for hours. And they go through, we haven't seen a big story of sudden death here, but you're talking about sudden death in young doctors. What about the rest of the doctors? I think this is something you need to explore beyond just young doctors. It's a frightening story you're telling us. But any lessons we can pick to give to other people? Omar? Is Omar there?
Thank you.
Go ahead, please.
Okay. The causes of sudden death are the same between young doctors and other doctors. As you mentioned before, the low salaries and long shifts in Sudan are the cornerstone of causes of sudden death in Sudan. Longer working hours and low salaries are the main causes in young doctors and others.
And do you think this has got anything to do with linked with the war situation? Is that what is causing this problem or exacerbating this problem? Is it linked to the war, or was this happening even before the war?
Okay, the last this occurred before 5 days ago for young Sudanese residents died the second day after long shift that extended 36 hours, 5 days ago.
Oh my God. Oh my God. This is very serious indeed. Losing a doctor who you take so long to train, that means all the patients they were taking care of, nobody's there to look after. This is a very serious problem. I really think you should share this publication wider. I know it may be online, but not many people know about this. Personally, I would be willing to share your publication amongst our doctors here. It's a serious problem. Very serious.
Hiba is probably here. Dr. Hiba is probably here, David. She would probably be able to speak a bit more about, the situation of the healthcare workers in Sudan during this current horrible conflict.
Absolutely. Dr. Hiba, please give us some insights on what's happening in the Sudan among healthcare workers, not just doctors, nurses, paramedical people, and so on. What's the situation? Is he able to talk?
No, she's probably she's been on a bad connection.
Hello.
Okay.
Good evening.
Yeah.
Greeting.
Welcome.
Hello.
Yes, please.
Peace be upon you. Greeting everyone and good evening, and thank you for very useful and important presentation and discussion.
Yes.
First, I would like to thank you again for providing this opportunity to speak on behalf of Sudanese doctor and present the view of pre-military committee of Sudanese doctor trade union regarding the current situation of health worker in Sudan during this during this war. And I will try to shed a light on the current situation in brief.
Yes.
So, as we mentioned, health workers are the backbone of the functioning and effective health system. Now, Sudanese health workers work under the armed conflict circumstance. And it is worth mentioning that due to the first of all, due to conflicting parties' behavior, the vast majority of the health worker are not recognized as a protected group as it is described by international humanitarian law defined in Geneva Convention. And nowadays, many hospitals are occupied by rapid support forces, and we find about 80% of them were partially or entirely destroyed, and a part of them, of the remaining, use as a military park and fighting platform, and health worker. Due to that, health worker face range of hazards: chemical, radiation, heat, noise, injury, harassment, psychosocial trauma, and more than that, some of them are arrested, and considerable number of health workers were kidnapped and forced to work under the threat of the gun. In addition, also health workers currently encounter this situation are severely unequipped and mostly find themselves providing their service in a way that does not fulfill the standard, which make them face a wide range of great occupational risk associated with infection and safe patient handling. Also, in addition, health worker in Sudan, as mentioned by Dr. Omar, and the situation become more worse, live in very poor environment in terms of availability of clean water, food, accommodation, sanitation, hygiene, and more than this, free movement and communication. Really, as also my colleague Omar said, health worker before and after after the war, more for long hours and under severe stress. And our record show several cases of deaths, murder, suicidal attempt. More than that, some of them were subjected to rape. Further, it is worth mentioning that the Sudan does not have Safety and Occupational Act. Instead, we have an internal regulation annexed to the Labor Act. And therefore, health workers face all these range of the risk without protection. And this is one of the challenges that is need to be addressed and converted to an opportunity, being a part of the core objective of health sector to protect and restore the health without causing harm to the patient and worker. All the above are documented, but we are certain that this is statistic represented by our trade union. It is show only the tip of iceberg and are not the final. I think I just repeated what said by Dr. Umar, but in more worse situation. Thank you.
Wow, we sympathize with the situation you are going through in the Sudan. Certainly, the war situation makes it very difficult for anybody to enforce any regulation, because who is in charge, gets very, very complicated. And maybe that's something we could also, as this team, draft out something, how to protect health workers in conflict situation, in war situation. Maybe WHO could help. How do we help to protect health workers in a situation of conflict? And certainly the point about there being no policy in place, specifically on occupational health there, is something that needs to be followed up, in my view, and that's a big problem. Policy, yes, we need a policy in place, but as I said earlier, policy also needs to be implemented. So we have a much more difficult situation. But thank you for sharing your experience, and we sympathize with the situation. We hope and pray that things get better. So I think we should open up. We have taken a bit longer than I think, Omar, you had suggested. I think we need to open and hear some questions and get the panelists to respond to those questions. Omar, who is compiling the questions? We can't hear you. You're muted. You're muted. Omar, you're muted.
Can I please ask you to see if Professor Khojali or Professor Gasana would want to add something to the panel? I think there is
absolutely, absolutely. Professor, we would love to hear your voice on this. This is an important issue we are discussing. It's not just a webinar. I think we need to come up with some direction that we can provide guidance to our governments, to our people on. This is a very important subject for discussion. Professor.
Hello.
Hello.
Do you hear me?
Yes, very clear.
We can hear you.
Professor Mustafa, you are muted again.
Am I muted now again?
Now you're okay. Please speak. You're muted again. Please unmute yourself.
Is it okay?
We can hear you now.
Huh? Do you hear me?
Now. Yes, you're okay now.
You are okay? Do you hear me?
Yes, please.
Yeah, and I think this was a very good session. But there was a focus bias. A session was supposed to be healthcare workers, and the focus was only on physicians and doctors. What about nurses, midwives, laboratory workers, who are the backbone of the healthcare team? And I think this should be addressed because they suffer more than the doctors, especially the nurses. They work harder and so on. I just wanted to, if in another workshop, to address and other members of the team, of the healthcare team, and nurses, midwives, laboratory workers, the cleaners, and so on. And it will be, and this is the sense of the occupational health within the healthcare. Just a comment, a general comment. Thank you.
Thank you, sir.
Of course, we are talking about health and care workers. Some of the people who provide care may not even be medically trained, but they do provide care for the sick and so on. I think our policy should cover all of them. But you're right, this is not an issue of doctors only. Nurses, paramedicals, laboratory staff, they are all healthcare workers, and we should have a uniform protection for all of them. Thank you very much for that point. Okay, any other?
Professor Gasana?
Yes, I really enjoyed the webinar, and these issues are really close to my heart. And I've been trained in medicine and public health, and having worked to put together the School of Public Health and the Department of Environment Occupational Health here in Miami, Florida International University. And I moved to Kuwait, and during COVID, I remember I organized a webinar teaching doctors, nurses. This time we include nurses, safety engineers, to tell them how to deal with the COVID. And you can see in a discussion forum we had, and they would, they had distressing stories about how some of their colleagues who didn't even wear masks end up being infected. They leave, and then the rest try to do the work, and they didn't want to go home to infect their families. So at that time, I invited actually a young psychiatrist from South Africa, and her talk was on self-care first. Yes, you're caring about the patients and everybody else, but if you don't take care of yourself, then you are not really useful somehow in that regard, because you be burned out, and so. And I hear all those stories, and it's just quite depressing to see what's happening in 21st century. And so that's why I'm glad that you invited me in this. I'll be sharing with you some of the initiatives that we have here. We're trying to use online technology to train, actually, basically the whole team. We talk about doctors, nurses, industrial hygienists, the occupational safety, everybody, because one of the reasons why, for example, occupational health is not really being doesn't make any progress. It's because we don't have trained people to educate those ministers who happen to be in Naror, but without any knowledge about occupational health. So if we train many people, hopefully this will bring the change in what we're doing. So it's really a big issue, and actually it's not just because there's a lack of economic means, because I live in Kuwait and they don't have that problem, money, but the way the whole thing was organized, and they still, the doctors are what's happened, and the nurses, everybody pretty much taken care of, and that's really a serious problem. So I think the best way to train to build the capacity in occupational health, and then you be training doctors, nurses, industrial hygienists, occupational hygienists, ergonomists, and it's when we have that type of team to be able to make any progress in trying to approach the politicians, the legislators, to tell them this is, we got a problem, because you have to have many people talking the same language to them, because otherwise the situation will linger for a long time. I share this concerns when I were at ICAR, the International Commission on Occupational Health in Marrakesh, and a few weeks ago we were in Orlando. We talked about this, and there's a move now trying to see if we can use the technology to try to train as many people as we can. And I believe that's the only way out of the problem we have here. So it will take effort, but I think we have the technology now. Let's find a way of using it. That's my take on this, because it's just really, the whole thing becomes almost like a vicious cycle. So yeah.
Wow.
Yeah.
Well spoken. I hear you loud and clear. And the importance of training, training and creating awareness is key. Training the healthcare workers on occupational health, we need an aggressive movement in that direction, but also create awareness among our leaders, politicians, and so on. They may not know, even when they have the money, they may not know that this is a problem. And I totally agree with you. Well spoken.
Thank you. Thank you, David. Yeah.
Any other comments? Anybody else wants to make a comment on this important subject? If not, Omar, maybe we should summarize the evening.
Thank you. Thank you very much, David. And thank you very, very much. I'm really grateful for, our panelists and all the attendees for a really, really, really good evening. And I think the summing up the really sobering, story young Omar presented to us today. I think that brought the whole thing really, really home. Dorothy, we really are grateful for your contribution. I think we will continue, to work very closely with you because we really don't want this to be just a talk and we go away. As David said earlier to Lawrence, these things are happening. They're happening, here and now, every single day. We're losing people every day. And it really isn't about doctors. Unfortunately, the speakers who, are all doctors. The people, we honor today. I was speaking with Dr. Hadir earlier, and this is a bias within the system. But I think the most important message is that I personally have, I have learned from here is advocacy for political commitment. I think this is a real priority because without that, you can write and draft the best policies and legal frameworks about protecting the healthcare workers everywhere, and nothing is going to happen. It is unfortunate that we did invite, the office of the commissioner, the African Union Commissioner for Health, to participate, but they said it was too short a notice, But again, I think these are people with the WHO and with the ILO. I'm not sure whether, Dorothy, you are aware that, was it last year, David, the WHO, the ILO, and the African Union Development Agency, NEPAD, signed an MOU to protect the health of the healthcare workers.
Yes,
My belief that is, that's a huge step forward. I really think it is. But I think it is left to people like you here that to make this operational. As Dorothy said earlier, drafting a policy or doing it, that is nothing, that's easy. It's very simple. The other thing that I think we really need to work on is, those waving flags, Dorothy presented. I can't tell you off the top of my head how many countries are in Africa. Much more than what we saw there. Much, much, much more. And you see countries where young Omar said, like Egypt, where there is a real health problem, although that's happening to doctors. God knows what's happening to nurses and to healthcare workers who are, if I may say it, down the ladder of the system there. If this is happening to the doctors, we got to increase the number of those flags there, even if there is a policy. I think what makes this really, again, important is training the healthcare workers to know there is a problem. I mean, I personally went through training in the Sudan, training in the UK. About okay. Well, I personally know about occupational health. When when I was doing surgery, when I was asked to go and check my hepatitis B status. No one, at least in the Sudan, probably in most of Africa, is asked about their hepatitis B status. Again, education and training is very important. I think that slide Dorothy put, summarizes everything, absolutely everything. We know the problems, we know how to handle them. It is really how do we actually organize ourselves and move on to do things. We're not going to solve the problems of the healthcare workers in Africa today or next week, but I really would suggest is at least the panelists here, would join us in, within Queer to form a group that would continue to look at this and maybe look at specific projects, training projects, advocacy projects in specific locations. And this is how you actually start. One of the things, again, David said earlier, and I really sincerely hope Dr. Hiba would take note of this, the healthcare, workers organizations. These are, major stakeholders in this. Again, one of the people I was really hoping to be part of this webinar were the Kenya Medical Association. I have written to the CEO, to participate, and we know. I think most of you know there were real problems in Kenya, not long ago. So if our colleagues in this workers' organization would take the safety, the whole picture of occupational health and safety as an issue, that would help push the agenda forward. So what my suggestion is we form a group, of us, obviously it's an involuntary group, and we look at how we can actually progress this further. And I would very much like to thank everyone who has attended today, and a very special thanks to our esteemed panelists. Thank you all very much.
Wow. Omar, I think that brings us to the end of our discussion. I would love to see this team formed under your leadership to move this agenda forward. It's too important to just leave it as a webinar. And my take-home message: advocacy, training, and among the health workers themselves, prevention. Let's talk about prevention also. You can be trained in prevention, but you can also find a way of enforcing prevention. And obviously, professional association, Omar, let's try to engage them in all these countries. Yeah. Engaging professional association, not just for doctors. The nurses have got their professional association, paramedics, and so on. I think let's bring them on board and bring the politicians also on board. In a future discussion, maybe we could invite some members of parliament to talk about this. The situation in Sudan is very worrying, extremely worrying. You cannot talk about regulations and policies when there's war, when there's conflict. So I think the prevention there is to stop the war. If the war continues, really you cannot engage anybody into meaningful discussion. So I am grateful for participating in this meeting, in this webinar, but let's follow it up. I thank you.
Thank you all very, very much. And yeah, it really was a pleasure having all of you here. Thank you very, very much.
Thank you.
Thank you. Bye.
Bye-bye, everybody.